Good afternoon. My name is Roger Nelson. I was the medical director at Queen's Park and Felburn Care Centers. Queen's Park and Felburn Care Centers are two freestanding long-term care facilities located in New Westminster and in Burnaby. There was a total capacity of 410 beds. I had been associated with Queen's Park Care Center. It was known as a hospital initially, first as a member of the MAC, then as a medical coordinator, and then lastly as a medical director for the last 10 years for both Queen's Park and Felburn Care Centers. The bylaws of these facilities state that the Code of Ethics is adopted or amended from time to time by the Canadian Medical Association shall govern the professional conduct of the medical staff. The articles that were most pertinent to the end-of-life issues were number 27, ascertain whenever possible and recognize the wishes of the patient about the initiation, continuation, or cessation of life-sustaining treatments. The second article, number 28, respect the intentions of an incompetent patient as they were expressed either through a valid advance directive or proxy designation before the patient became incompetent. And the last article, number 29, when the intentions of an incompetent patient are unknown and when no formal mechanism for making treatment decisions is in place, render such treatment as you believe to be in accordance with the patient's values, if these are unknown, the patient's best interests. There are a number of factors that affect the treatment decisions in the care of the elderly. The elderly patients are at a greater risk for life-threatening and severe disabling conditions. This raises questions of how extensively or how aggressively to treat. These patients often find life-sustaining technologies objectionable. There is a limitation of resources available to this high utilization group. And physicians have a fear of litigation for acts resembling euthanasia. However, withdrawal of life support, sometimes referred to as consensual passive euthanasia, is legal and ethically defensible and can convey a legal and moral duty. Withdrawal of life support in our facilities consisted of withholding antibiotic therapy, IV hydration, not instituting or withdrawing tube feedings, and DNR orders, do not resuscitate. Adults capable of making their own decisions have the right to refuse unwanted medical treatment even if it is life-saving. They can refuse artificial nutrition and hydration. It is also ethical to perform interventions designed to keep patients pain-free even though it may reduce their lifespan. Advance directives, living wills, representation agreements are documents that indicate the wishes of the individual regarding end-of-life care. Advance directives and living wills are useful in guiding medical decisions in this realm. The representation agreement names the person chosen by the individual to make legal decisions on their behalf, and this person is known as a representative or proxy. When an adult is no longer able to make decisions for themselves and has a representation agreement, then the representative or proxy becomes the surrogate decision maker. The representative must make the decisions or choices as the patient would have made them if they were competent. These decisions on behalf of the patient will be made based on previous statements or expressed values of the patient. Or, if these are not known, the decision must be made in the best interests of the patient. Obviously, the key to the harmonious functioning of these directives is communication. Discussions with patients about their preferences, about resuscitation and other end-of-life issues are complex and can be time-consuming and challenging. Patients may not fully understand treatments and outcomes, or they may have difficulty formulating and expressing preferences about future situations. Patients may also change their minds when faced with the actual decisions to forego life-sustaining treatments. A significant number of patients have no wish to confront their own mortality. This wish should be respected. The family should be fully involved and informed of these decisions. These documents are limited by our ability to fully anticipate future medical circumstances and are often lacking information specific to the patient. Therefore, the assistance of family members is required and helpful with interpretation. It is of interest to note that unless the children or the family members are legal guardians of the patient, then their personal wishes as to the end-of-life decisions for the patient are not legally binding. The most difficult problem is when an incompetent patient is facing difficult end-of-life problems and there are limited advance directives, absent living will or representation agreements. The advance directives or degree of intervention guidelines are sufficient to guide end-of-life care for the majority of patients. However, occasionally a proposed withdrawal of treatment which is life-sustaining arises, such as removal of a feeding tube. Fortunately, at our facilities, we did have an ethics committee. These difficult problems were referred to the committee. Input was solicited from family members or other significant individuals and medical personnel who cared for the person. The committee tried to assemble all available information about the patient's values and attitudes pertaining to the end-of-life issues and come to a finding that was consistent with these values and in the patient's best interests. I was asked to tell you of my experiences during my tenure at Queen's Park and Felburn with physician assistant deliverance. I'm afraid that my experience was not very challenging, as I was never approached to assist in a suicide. One of the probable reasons for this was during the last 10 years I did not do any clinical care, direct patient care that is. I undertook an informal poll of 5 staff physicians, asking them their experiences in this regard. All these physicians had the largest number of patients in the 2 facilities. These are their observations. 2 physicians had never been asked to assist in suicide. 2 doctors had been approached once, but not in a persistent manner. One doctor stated that he had been approached about 20 times to assist in a suicide or euthanasia, but he felt that only about 1/2 of these requests were serious. It is interesting that none of these physicians said that they would ever participate in an assisted suicide. One of the reasons that there were not more requests to physicians from patients to assist in ending their lives is that when a serious or terminal diagnosis was made, a discussion of a palliative treatment plan was initiated. These discussions and ensuing actions on behalf of the patient probably forestalled many requests for assisted suicide. Hopefully, the palliative care assisted the patient by maximizing comfort and pain relief and allowed a death that was with as much dignity as possible. Both the Canadian Medical Association and the British Medical Association have specifically opposed any changes in the law that would legalize euthanasia and/or physician-assisted suicide. Traditionally, both acts have been perceived as identical and violate the moral focus of medicine. However, both medical associations have acknowledged that a significant number of health professionals feel that a substantive distinction exists between terminating patients' life and allowing patients to kill themselves. These associations have invited wider debate within the profession about euthanasia and assisted suicide. Society has clearly shown its concerns with the problems of dying. The medical profession feels that adequate palliative care should be available to all citizens before assisted suicide or euthanasia is considered for legalization. Thank you.